Welcome to the COE Fidelity Guidelines tutorial on enrollment. In this tutorial, we will be reviewing the third section of the COE Fidelity Guidelines, Client Enrollment. We do want you to be aware that the slides that we are using for this tutorial present the Fidelity Guidelines along with additional resources to support guideline implementation. The written items on the slides themselves may be an overview of a guideline in some instances, so you should refer to the full Fidelity Guidelines document as opposed to the slides used in this tutorial if you need a reference of the written guidelines in their entirety. An important first point about COE enrollment is that enrolling clients in the COE requires a formal interactive process that cannot be automated, such as assigning clients to the COE, and must include the following requirements. All clients who are eligible for the COE must be provided with a brief description of the program, either verbal or in writing, and all clients must sign a formal consent to enrollment in the COE before they can be enrolled. This consent is an acknowledgement and acceptance to receive COE services. COE consent forms should include language that indicates the COE as the client's choice of provider for COE services. For warm handoff or WHO encounters, enrollment in the COE may be delayed until the person can understand the purpose of the COE program and provide consent for COE activities. It is recommended that COEs delay enrollment until the person's readiness for treatment can be determined. Appendix 6 provides a sample consent to enrollment form that can be adapted by any COE who doesn't currently implement this process. Requirements in the MA Bulletin for COE enrollment is providing at least one form of medication approved by the Food and Drug Administration for use in MAT at the enrolled service location in which COE services are offered, and to schedule individuals eligible to receive COE services for MAT induction within 24 hours of the COE member's initial encounter with the COE provider. The enrollment section of the Fidelity Guidelines reiterates the importance of rapid access to MOUD. If you're not sure what rapid access policy you included in your original COE application, you can reach out to your Peru point of contact to discuss. The Fidelity Guidelines state that COE programs are encouraged to offer rapid access to MOUD before or during the enrollment process, but must not delay access to MOUD while completing the COE enrollment process. In other words, initiate buprenorphine or methadone rapidly while completing the COE enrollment process. A person may receive MOUD but decline the COE program. It is recommended that COE clients who consent to receive MOUD are inducted on MOUD within 24 hours of initial contact as outlined in the MA Bulletin. Pathways to prescribers can include, but are not limited to, prescribers on the COE team that offer on-site inductions, telehealth if the COE prescriber is not on-site at the time of enrollment, telehealth prescribing by a bridge clinic, or same-day referral and access to a verified COE partner prescriber. COEs were required to outline their process for rapid MOUD induction to enroll as a COE provider. These processes should be updated in the COE service description as changes are made. Rapid access to MOUD is encouraged as a parallel process to the COE and not after these steps are completed. COE clients are not required to be on MOUD to receive COE services. MOUD is client choice. COE staff should encourage the use of MOUD as an evidence-based best practice. There are important benefits of COEs offering rapid induction to MOUD, which is why this is emphasized alongside the enrollment guidelines. Rapid MOUD induction provides prompt relief from painful and uncomfortable withdrawal symptoms often experienced by individuals with opioid use disorders. This can make the initial steps of recovery more bearable and encourage continued treatment. The period immediately following a decision to seek treatment is critical. The longer the gap between this decision and treatment initiation, the higher the risk of a return to use. Rapid induction minimizes this gap. Research also says that when clients experience the immediate benefits of MOUD, they are more likely to stick with their treatment plan, leading to better outcomes. Rapid induction into MOUD not only helps to prevent clients from returning to use, but can also lead to improved overall health, better social reintegration, and reduced criminal activity among those with opioid use disorders. Finally, rapid induction improves engagement. Clients seeking SUD treatment are 7 times more likely to be engaged if they are seen on the same day compared to waiting 2 or more days. After acquiring consent for COE services, the following additional steps for enrollment should be completed. A meeting with a COE team member, preferably face-to-face, but it may occur by telehealth. This will likely be the same person acquiring the consent and providing the overview of the COE program. If the referral is a warm handoff, it may require more than one meeting. A few notes about the first meeting include that the selection of a face-to-face meeting versus a telehealth meeting should be based on the client need and preference. Telehealth meetings should follow Organizational and PA Office of Medicaid Programs and Office of Mental Health and Substance Abuse Services policies. Face-to-face meetings can occur in the office or in the community via mobile engagement. For enrollment, a client should also receive contact information for their COE team should they need to contact them for support prior to the next scheduled appointment. The COE should determine that the person resides in or is going to reside in the service catchment area and can receive care management services. COE-specific enrollment paperwork, including ROIs for providers in the area to allow for coordination of care and ROIs to release de-identified data to MCOs, DHS, and Peru should be completed. COEs should document in the client's chart the outreach to other COEs, MOUD, and care management providers in the area to avoid client duplication. Lastly, after acquiring consent, the COE should complete a rapid assessment of needs and a rapid care management plan. One of the items within the COE-specific enrollment paperwork was the need to reach out to other providers in the area to reduce duplication. This is important because each COE client should only be enrolled in one COE. Upon enrollment, a COE should ensure that the client has not been enrolled for COE services elsewhere. Appendix 7 provides a sample process for minimizing duplication at enrollment and client duplication FAQs. A few items mentioned in the enrollment section may be new terminology, but may be things that many COEs are already completing. The rapid assessment of needs can be brief to cover basic requirements, including a review of immediate HRSN/SDOH needs, referrals to address these immediate needs, a suicide risk screening, and the provision of MOUD education. More detailed data collection can be collected over the following days or weeks. Something to note regarding screenings is that if any screening tool, such as the GAD-7 or CSSRS, was completed by staff outside the COE, such as an outside agency, or an SUD treatment department of the facility on the same day as COE enrollment, COE staff should obtain and review those results with the client and determine if an assessment is needed. COE staff should document in the client's chart that these screening results were reviewed and updated as needed. If clinically appropriate, the screening should be repeated at COE enrollment. The Rapid Care Management Plan should focus on helping the person stay engaged in COE services and substance use, mental health, and/or medical treatment services. A more detailed plan can evolve over time. A Rapid Care Management Plan is intended to reduce the risk of disengagement during the initial 30 days of COE enrollment. It is recommended that COE staff focus on the highest indicated needs. It is recommended that the Rapid Care Plan and strategies for preventing disengagement be documented in the client's intake note in their electronic record. Appendix 8 provides COEs with a sample rapid care plan template, while Appendix 9 provides sample strategies for disengagement, since these are part of the rapid care management plan. Once these requirements have been completed, the enrollment date must be entered into REDCap under the date of initial contact field on the client profile form. This date will begin tracking retention by Peru. On the client's COE enrollment date, several important tasks must be completed. First, the client's eligibility for COE should be confirmed using the inclusion criteria. Next, all intake assessments and screenings need to be conducted and completed in entirety, ensuring that they take less than 120 minutes. On the client's COE enrollment date, a rapid care management plan should be developed tailored to the client's specific needs. Additionally, all COE-specific enrollment paperwork must be completed. Finally, the client should be introduced to their case manager, ideally through a face-to-face meeting rather than a phone call or referral. If additional information is required, that can be assessed during a subsequent meeting, but enrollment is considered to have occurred at the completion of all the above activities during one session on one calendar day. The above must be documented in the client chart. In addition, every COE should ensure that staff involved in these enrollment activities have received training in conducting the activities and in evidence-based patient engagement strategies. COE staff have up to 1 year to complete required training. COE should select staff training that is best for their model and staff makeup. They may reference relevant DDAP trainings as necessary. COEs should keep documentation of completed trainings and organizational training logs. The MCO can confirm through chart review that the enrollment activities have been conducted in the first visit for each client. These enrollment activities are those that were previously mentioned in the COE guidelines section: the meeting with a COE team member, determination that the person resides in or is going to reside in the service catchment area, COE-specific enrollment paperwork, rapid assessment of needs, and the rapid care management plan. The MCO can also confirm through chart review that there is an enrollment date for each client that corresponds to their rapid care management plan development. MCOs can confirm through submission of training logs that the COE staff have received training on enrollment processes and evidence-based engagement processes. The last MCO monitoring item in the enrollment section is that through chart review and/or a review of COE's policies and procedures, MCOs can confirm the documentation of items related to enrollment outlined in the Fidelity Guidelines documentation guidance. There are 3 items related to enrollment that should be a part of the COE's policies and procedures. These are a copy of your consent form for COE services that includes the COE as the client's choice of provider for COE services, a copy of your client-facing program description that explains the care management services offered and the potential benefits of enrollment, and training plans for all staff involved in the enrollment that include engagement best practices like motivational interviewing, which should be updated regularly to indicate that training was completed. There are several documentation items for COEs related to enrollment. However, many of these are likely part of most COEs' current processes, and if they are not, they should be relatively easy to incorporate into notes within the chart. First, COEs must document the client's client ID. This should be documented in the client chart and in the quarterly crosswalk that COEs provide to DHS that shows the link between the client's MAID and their REDCap ID. COEs should also document the client's COE enrollment date in the client's chart and in REDCap. Documentation that the client resides in or is going to reside in the service catchment area and can receive care management services should be included in the client's chart. Documentation that COE staff had a discussion with the client verifying that the client is not enrolled in another program that may be duplicative should be in the client's chart. ROI COIs that were signed for providers in the area and that the client acknowledges involvement with these providers that allows for coordination of care should be included in the client's chart. The outreach that was completed to other COEs, MOUD, and/or care management providers in the area to avoid client duplication should be documented in the chart. Signed ROIs to release de-identified data to MCOs, DHS, and Peru should be documented in the client's chart. Documentation that the client received an overview of the COE program and consented to receive COE services should be documented in the client chart. The signed consent form should be in the client's chart and should be indicated in the REDCap client profile. Documentation that MOUD education was provided should be in the client's chart and indicated in REDCap on the client interaction form. Documentation of the client's MOUD acceptance or refusal should be in the client chart. Documentation that the client met with a member of the COE community-based care management team, including the team member's position such as care manager or CRS, should be in the client's chart and in REDCap on the client interaction form. Documentation if the COE community-based care management meeting occurred in person or virtually should also be documented in the chart and REDCap. It should be documented in the client chart that the client received contact information for their COE team should they need to contact them for support prior to the next scheduled appointment. The needs identified by the rapid HRSN SDOH assessment should be documented in the client chart and in REDCap as need indicated. Documentation that a suicide screening was completed with the client, the screening score, and the recommended follow-up and referrals placed, if necessary, should be documented in the client's chart and in REDCap. Documentation of referrals placed for any immediate needs should be documented in the chart and in REDCap. Lastly, the rapid care management plan that identifies immediate needs to reduce risk of overdose and reduce barriers to COE attendance should be documented in the client chart and in REDCap. These are the references used in this tutorial. Thank you for joining me for this tutorial about the enrollment section of the COE Fidelity Guidelines. Please contact your Peru TA provider with additional questions or requests for support.